is not the algorithm, how we access a lesion once the wire is gone but the gear won't go. So basically the balloon in Proxibles, the problem is that we are not able to pass anything except the wire. So the different strategies that could be applied is either to modify the lesion or to increase the support or to change the deliverable. And if it is just not possible, then come retrograde. And we should decide the right amount of force that we actually want to use, because once we use the inadvertent force, we might enter the pericardium. Most of these lesions that are balloon uncrossable are usually negatively remodeled vessels with dense fibrotic plaque or a calcific plaque with a nodular calcium protruding into the lumen. And we should be especially cautious in mid-LAD where we have eccentric calcium on the myocardial aspect, or we are facing a balloon uncrossable lesion in a tortuous lesion in LCX or RCA. Because the price that we might have to pay in such a lesion being over-aggressive is the coronary perforation. So my first case is a 69-year-old diabetic who underwent a PTCA to LCX in 2011 and an intervention tried for LAD CTO in 2018, but continued to have class 2 angina with recent progression in angina. And this is the angiogram that shows a dominant left circumflex artery and a total occlusion of proximal LAD. You can appreciate the bend in the lesion, the long occlusion length, as well as the calcification. And with the JCTO score of 4, we tried to intervene in this LAD. With a microcatheter support, we were able to enter with the feeder XT wire with relative ease. But the wire would go, but the microcatheter would just not go. We had a gritty feeling. We confirmed the wire. We just had the antegrade approach. In this case, the RCA was having a fistulous connection. There were no significant collaterals, so the only way was antegrade. The lesion was ankulated, and any attempt to advance the microcatheter antegradely would just push the guide back. We did attempts at redilating it with the shortest balloon on shelf that day, that was 1:6 balloon, that had accidental granuloplasty but not of much help. So after 1 hour of effort, we were almost falling a day off. We were not able to get any significant antegrade flow. But the moment we took the wire out, possibly it was the balloon that was wedging on the lesion, and we could see some faint antegrade flow. So we started the day again, started with around 1.25 into 6 to 8 millimeters NC balloons. And this time we intentionally did granuloplasty with approximately 3 balloons, and we can see a better antegrade flow. And at this point of time, it's either U214s or the plane 214s. So this time again, we had to wire it again across the lesion because we took the wire out. And this time we thought we'll just do a quick assessment of the proximal LAD to see whether we have dissected the segment much enough so that anything could just pass. But neither a balloon or a microcatheter would pass. And the proximal LAD assessment showed sheets of calcium. This is the proximal segment. And the only way out would possibly be a rotablation. But the point is that it required an exchange of rotawire. Since no other maneuver was working, we just buried the microcatheter as much as possible into the lesion and attempted to put in the floppy rotawire. Although at this point of time, the tilt technique could be tried. We could have used a guide extension catheter into the proximal part with a 8 French guiding catheter and a microcatheter, maybe 6 French, anchored it with a proximal balloon and then tried to enter the microcatheter. But at that day, we were lucky enough to just slip in the floppy rotawire. We started with a rota 1.25 bar, and we could achieve a reasonable antegrade flow followed by a MC balloon dilatation. And this is the IVUS pullback that shows significant concentric calcium, and since this has been modified, we could achieve a good antegrade flow and the lesion was completed. This is the story and the intervention was completed. So this is a story of an occlusive disease, but sometimes it can happen in non-occlusive diseases as well. This is a relatively simple looking lesion, but again we were unable to cross even a 1 into 6 mm balloon despite having a buddy wire in place. And again, we did an intentional granuloplasty with 2.5 into 10 NC balloon once it was across. And we, since there was heavy calcification as documented on iris, we followed up with the IVL. And after documentation of calcium fractures, cavitations, and spallation, even at distal areas of calcium, and giving additional 20 more pulses, we completed this intervention with a reasonable result. And again, certain simple looking lesions possibly have certain calcium nodules that are protruding into the lumen, and we might use a lower profile balloons like Nick Nano that may give us way for further devices to go. So to summarize the step 1, using small single marker compliant balloons with low crossing profile and long lengths may sometimes help us through. Rapid exchange balloons have a stiffer shaft and may potentially facilitate advancement to the lesion. We should try the balloon wedging technique and try with a new small balloon since balloons do not return to their original profile even after single inflation. And sometimes a larger 2.5 into 3 mm rapid exchange balloon proximal to the lesion might disrupt the architecture to help us get to a smaller balloon in the subsequent attempt. Next is the use of granuloplasty, also known as balloon-assisted microdissection, that almost helped us in all these 3 cases. So this was the step 1. The next step is to increase the support by using a guide that is more confirmation or changing the route from radial to femoral to provide us more support. The use of guide extension catheter, especially with buddy wire. Like in this case, we used an inch-worming technique to advance the guide slowly towards the lesion over a deflated balloon with each event. Using proximal or distal anchoring techniques, some special techniques like buddy wire stent anchoring technique by anchoring a proximal wire, jamming it up, and then trying to attempt to deliver the device through the device that is across the CTO. And especially crossing lesions through a stent is difficult. That might be used with a similar technique as a stent deflection balloon or an instant anchoring technique that we usually use. Use of microcatheter itself might sometimes modify the balloon uncrossable lesion, but we have certain plaque modification microcatheters like the Taunus or Turnpike Gold that are graded and coiled enough and help us across, especially in cases of CTO ISRs. This was a case of RCA ISR CTO that was done with a Taunus catheter. The next technique in this regard are the wire cutting technique, in which we advance the balloon as close to the CTO as possible and try to place a stiffer wire across the parallel to the wire over which the balloon was placed. And once the balloon is inflated, just pull back the second wire that might modify the proximal cap sufficient enough to let the balloon go. Next is the seesaw balloon technique, in which we place 2 balloons and alternately inflate balloons one after another until the lesion just fatigues and gives way. Next is the modification of these multi-wire plaque crushing technique, in which one polymer jacketed wire is advanced and another stiffer wire like Miracle 3, 6, either 1 or 2 wires are used, and similarly balloons are used in a crowbar effect to get across the lesion. And last are the subintimal techniques, in which we cross the lesion and another wire is placed in a looped fashion across the subintimal area, and then that subintimal area is externally crushed with a small balloon to either modify the lesion or it is get passed across the lesion and a distal anchor is done to actually anchor the distal wire and let the lesion be crossed from the proximal side with the wire that was placed earlier. So these techniques might be used sequentially, might be used simultaneously, especially with aorta ablation. We should not try to attempt dissecting the vessel earlier and then try aorta. It is always better to go upfront aorta in such patients to modify the lesion. And a combination of these techniques might help us get across these difficult lesions. Thank you.
Thank you, Dr. Anuj.